Hello, my name is Graham Johnston. I'm a consultant anaesthetist at Aberdeen Royal Infirmary, and today I'm going to talk about a technique for the situation where there's a critical narrowing of the airway, and you might anticipate that if you use the fibrescope you'd get a cork in the bottle situation. So this is usually in a situation where you've got a laryngeal malignancy and you have maybe post-radiotherapy and you've got a very, very critical narrow opening. Nasal endoscopy has shown that the opening may be down as little as 3 or 4 millimeters diameter. External diameter of the fibrescope, the standard Olympus fibrescope or the ambuscope is 4 to 4.2 millimeters, and passing that scope through this critical narrowing would cause complete blockage of the airway. So alternative techniques for this would be front and neck access and be very limited in terms of what you could do, or a high-risk general anaesthetic. And this technique enables you to use the fibroscope and pass a very narrow tube through the opening without ever passing the fibroscope through the critical anatomical narrowing. The available tubes therefore are either the cochlear exchange catheter, the very narrow one, which is 8 French, which is less than 3 millimeters out to diameter and 45 centimeters long. Or we can alter the Hunsaker tube by removing the green cage at the end of the Hunsaker tube, because this simply will not railroad over a wire. So we have to remove that with heavy base scissors, ensuring that we get a nice clean cut and there are no sharp edges at the end of it, and use that as an alternative. Either tube will work. Obviously, modifying the Hunsaker tube is an off-license use. You may prefer to use the cochlear exchange catheter because it does not need to be modified. It is about the same diameter. It is less than 3 millimeters external diameter. So the other critical piece of equipment for this technique is a long, soft-ended ureteric stent wire. This has to be narrow enough to pass through the working channel of the fibroscope and long enough that we're able to have a part of it in the trachea and part of it long enough to withdraw the scope from the mouth. Setup is as it would be for any standard awake fibre optic intubation. We will follow the DAS guideline of stop, sedation, topicalization, oxygenation and perform. It's possible to do this orally. You will get a slightly more stable view of the supraglottis if you do it nasally, but either approach will work. Topicalize the nasal airway and then use the fibroscope down towards, visualize the laryngeal anatomy and spray directly onto the cords. Normally we would use around about 4 mils of 4% lignocaine to do this. A vital component of this technique is that we allow the local anaesthetic to work. It takes at least 5 minutes for this topical 4% lignocaine to be effective. So after topicalization, it is essential that we wait 5 minutes for it to be effective before we touch the anatomy in any other way whatsoever. Once we're sure that topicalization is adequate, the patient is sitting upright, we're ensured oxygenation. We're going to pass the fibroscope through the nose down to just above the larynx. We will then pass the ureteric wire through the working channel of the fibroscope until we watch it pass through the airway and down into the trachea. Pass it down the trachea until it touches the carina. This will be evidence because the patient will always cough. Once we've seen that the guide wire has passed properly through the very narrow part of the airway, we're going to keep the wire in place and withdraw the fibroscope from the patient, ensuring that the wire stays in exactly the correct place. We'll then insert the fibroscope again, probably through the opposite nostril, to give us a supraglottic view of the pathology with the wire passing through the narrowing into the trachea. Now we have the supraglottic view of the pathology, the narrowed airway, with the ureteric wire through the narrowing. We can now thread either the narrow air exchange catheter or the altered Hunsaker tube down over the wire. As it passes through the pathology, we'll be able to watch this with the fibroscope to make sure that it passes rather than buckles, and we'll advance it 8 to 10 centimeters beyond that point to make sure that we're properly into the trachea. Now that we have a good supraglottic view, that we have passed either the airway exchange catheter or the modified Hunsaker tube through the pathology, we will remove the wire. we will remove the fibrescope and we will attach the capnograph to the side arm of the Hunsaker or to the end of the air exchange catheter to ensure that we get a capnograph trace showing that we're properly in this trachea. Anesthesia can then be initiated with TIVA. Once the patient is asleep, we're going to start using the jet ventilator to oxygenate the patient and ensure oxygenation. It's imperative to remember that we have a very small expiratory airway here. We have a potential to give quite a big tidal volume through the jet tube, but our expiratory airway is the annular airway between the internal diameter of the airway, the anatomical airway, and the external diameter of our tube, and that will be a very small annular airway. So we've got to allow a long expiratory time to allow any tidal volume that we put in with a jet ventilator to escape, and that may require a 10-20 second expiratory time. We have to allow permissive hypercapnia here because that's not a worry in this situation for a short term. We have to concentrate on oxygenation.